Okay, so this is a radix graft. This is going to be the caudal end, and it's tapered. And this will be the cephalic part, corresponds to the supratarsal crease. So the way to place this, first we flip it over. We've obviously beveled the edges very nicely, and we'll actually crush it at the end just a little bit. So we flip it over, and we go from bottom to top, and then just hold this left over. Yep. And I'll take those cartilage forceps, and I get a needle driver, and then we take our suture and go from top to bottom, and then what we do is we tie this again very, very lightly, because we don't want to cut through the cartilage. But we want to use this, it will help with the placement of this so it stays in midline. Because the pocket, if we do take some dorsum down, if you think of the pocket principle as making a very, very accurate and precise pocket and putting the cartilage in, that's typically what we do when we're placing cartilage grafts. Well, it's almost impossible to do that with a radix graft, because the optical cavity you create in taking down the dorsum is much bigger than the radix graft, right? Okay, so go ahead and cut that there. So now we've got it sutured in place. I like the knot on the bottom so it's not right under the surface of the skin. And then I'll just take this graft, and what I do is I go now from bottom to top. Just keep an eye on this, from bottom to top. Let me hold the other end of that graft, I just don't want to break it. And then as I come out the other side, take up the slack. Okay, let go, and we flip that over. And now we note that where it's exiting the graft in the cephalic end is about 2 millimeters below the leading edge, and that's where we're going to make reference. You'll see when we place the graft. So placement of a radix graft is a question we get often. We've marked out the where the supraciliary crease is here, which is where the starting point of the nose should be, and that should be where the furthest end of the graft is, the leading end. So in placement, we've put this on a small pair of forceps that we will be able to set in the nose, but we do want to be able to anchor that in place. So I'll take the converse. I apologize for the headlight, but basically we've taken a very little bit off the profile, and we are always much better off doing a little less reducing in the midsection of the nose and building up where it's weak in the tip and the radix than overdoing the dorsum. So what I'll do now is, could you just hold maybe that? That's good. So I've got my suture, and I'm going to look up into that optical cavity that we've created. It's a 5/0 chromic that we've placed on previously, and then what I try to do is try to pop through. Okay, about 2 to 3 millimeters below that mark. Small forceps, please. And in doing so, we know, because the suture has been placed on the leading edge of the cartilage, a couple of millimeters below that. So if we put our forceps right up to the end of it, where we bring this through and we anchor it, that graft will then not shift from side to side or even move on the dorsum of the nose. Again, keeping in mind that the pocket principle, there's a bigger pocket, and so we have to do something to secure it in place. And now we've put that graft in place. It sits there and has, in essence, lengthened the nose, minimizing the amount that we need to take off the profile. And what I like to do, needle driver please, is I just anchor this in place right up here at the dorsum. I put a little stitch, and now that holds my graft in place for the first week. Actually, yeah, for about the first week, but actually after a couple of days that graft is not moving because it will be underneath the splint. Go ahead and cut that now. It just goes, so that shows how we place a radix graft in the nose, and then we will move on to do our osteotomies.